The views expressed on Science for the People are not necessarily the views of this station, its affiliates, sponsors, or advertisers.
Ebola has been in the news almost constantly for the last few months. On today's show, we've tackled the outbreak from a couple of different perspectives. Later on, Desiree Schell will be talking with Tara Smith, infectious disease epidemiologist and blogger, about how Ebola cases are being handled here in North America, the way the media is covering the story, and the way the public is responding. And I'll be back to speak with Vincent Racaniello, an immunologist and microbiologist, about the current status of experimental Ebola treatments and vaccines. But first, Desiree Schell is speaking with Dr. Tim Jagatic.
Welcome to Science for the People. I'm Desiree Schell, and I'm joined by Dr. Tim Jagatic from Windsor, Ontario, who worked with Médecins Sans Frontières, or Doctors Without Borders, helping to fight the Ebola outbreak in Guinea and Sierra Leone over the past year. Welcome, Tim.
Thank you for having me.
Okay, let's start with some background. What is Ebola exactly?
Well, Ebola is a virus. It is considered a hemorrhagic virus, but actually the classification of it has been changed simply because the number of hemorrhagic cases that we actually have is fewer than 20%. So now what we call it is Ebola viral disease. And like I said, it's simply a virus. This virus is it's spread through close bodily fluid contact. And once it enters the body, it goes through a particular process, which essentially causes a sickness with symptoms that are very similar to the flu. And what we do and how we treat it is based on the symptoms that we see, because we don't actually have an actual drug, an antiviral that can directly attack the virus. We just find the symptoms, wait for the symptoms, treat the symptoms. And through this process, we are able to help many patients.
So let's break that down. What are the symptoms?
Symptoms are, all right, when a patient first starts with symptoms, they typically start with these very nonspecific symptoms, which include fever, muscle aches, fatigue. These types of symptoms are associated with so many different diseases. That's why we call it nonspecific. And then throughout the progression of the disease, they start to develop a bit more severe symptoms, such as vomiting, diarrhea, profuse diarrhea, and profuse vomiting. And then this leads to a loss in blood volume because they're losing so many fluids from diarrhea and vomiting. And that's when we start seeing a lot of the complications, which are then attributable to many of the deaths that occur from the disease.
Now, how does it travel through the body?
Well, it has to go through one of the mucous membranes. So that includes the eyes, the nose, the mouth. And what we're seeing is that patients tend to be people who are in very close proximity with other sick people. Now, in West Africa, we have to understand there's a completely different context in terms of healthcare and hygiene than there is in the West. Because the healthcare system was so weak to begin with, many people don't even bother going to a hospital or a healthcare setting whenever a loved one gets sick. What they do is they keep that person at home and they take care of them themselves. Now, in this situation, when you have somebody who is having a lot of vomit and diarrhea and they're in the exact same room with the other person who's taking care of them, sometimes they're cleaning that up, sometimes they're actually being vomited on. This increases the likelihood significantly for the disease to be transmitted. And that's why we're seeing the disease being transmitted so quickly. So I understand a lot of people in Canada are saying, well, if this is so difficult to get, why are so many people getting it? And it's because it's happening in this completely different context.
So then what's the progression of the virus? What do we eventually see?
Well, we know that the virus, once it gets inside the body, it replicates very quickly. We know that it loves the liver and it loves blood vessels. And when it gets to the blood vessels, it has the blood vessels release inflammatory mediators. And what that means is, it means that the body itself has the ability to say there's something wrong. But when the virus gets in there and forces the body to say there's something wrong all throughout the body, then that response can become extremely complicated, and it actually does more harm than good. And that's when we start seeing the blood vessels become a little bit what we call leaky. There's not actual there's no blood loss on the inside, but there's fluid loss on the inside of the body. So patients are having what we call, are in a state of hypovolemic shock. that means that they've lost a lot of fluid and that they're not having the proper blood movement through their body. They don't have the proper compensation. They're not getting enough oxygen to their organs, and when their organs don't get enough oxygen, they start to shut down. And that's why we're seeing a lot of death associated with this disease. Because what we're noticing is when we're able to put fluids back into the body, and we're able to keep that volume at a normal level, and the oxygen is able to flow to the organs, we're having much better results. So it's very important for us to keep those volumes of blood stable and normal, so that the blood can keep on moving through, providing oxygen to the very important organs such as the liver and the kidneys.
And how long does Ebola live outside the body?
Ebola lives outside the body for a very short period of time. Within half an hour, first of all, if it's in a droplet and that droplet dries out, it's dead. It's gone. You forget about it. We see that with 30 minutes in UV light is guaranteed to kill it off. It probably gets killed off much sooner than that. With chlorine is able to actually destroy the envelope of the virus, so the outer lining of the virus, as well as soap and water. Like, this virus is very weak, physically speaking. If you have Ebola on your hands and you wash your hands with regular soap and water, you kill the virus. End of story. Very simple. And these are a lot of the advantages we have against the virus, that it's very weak physically. It doesn't have the ability to move from person to person over great distances. And if it lands on a surface and that surface is cleaned up or dried out, the virus is dead.
You are very reassuring. Well, then, because as I said, you are reassuring. So then how did the current outbreak start then? Could you give me a bit of a chronology?
Yeah, so in terms of when we actually realized it started to happen, that was around March. When we believe it actually started was around December. But the reason that we weren't able to connect the dots as quickly as one would hope we did was because this virus was only ever seen in sub-Saharan Central Africa, so the Democratic Republic of Congo, Uganda, Sudan. These were the areas where we traditionally saw the virus, and for about 40 years we saw the virus only there. Now, in West Africa, we started seeing symptoms which could have been associated with malaria. It could have been associated with cholera. And when we saw a handful of these patients coming to the facilities, and we were treating for malaria, we were treating for cholera, we weren't getting proper results. Like, they should have not been dying based on the treatment they were getting. So we started wondering what was going on. Then we started seeing there was a few patients who had hemorrhagic signs, which means there was some blood coming out. There was bloody diarrhea, there was bloody vomit. But even that itself isn't telling of a viral hemorrhagic disease, because you can have bloody diarrhea with all sorts of bacterial diseases, which are very easy to treat, like typhoid. So it started to get a little bit more suspicious. And then finally, when somebody realized that this could possibly be Ebola, was when a patient came in with hiccups and all the other signs. Now, hiccups are a telltale sign of Ebola. We don't know what the pathophysiology is behind that, but when we see hiccups in a patient who is suffering from Ebola-like symptoms, that is a high suspicion of Ebola. And that's when they decided to start taking blood samples and send it off to France. Now, it's very important for people to understand the geographical differences between West Africa and sub-Saharan Central Africa. There's about 5,000 kilometer distance. So we're talking about Toronto to Vancouver. That's the distance that we're talking about in terms of this disease. That is why we weren't able to recognize this disease right away, because who is expecting a disease to travel that far? Well, it just wasn't on the radar at first. But when we finally figured out that that's what was going on, we quickly mobilized and we started to set up our treatment facilities. And this started in a small village in Guinea called Gikadu. Then we picked up a couple of cases in the capital city, Conakry. And that was when we had alarm bells going off within the organization. That's when we started saying, epidemiologically speaking, this could be a potential problem, because this is the first time that we will be seeing Ebola in a large urban environment with a lot of mobility and poor levels of hygiene and healthcare. Like these are all factors which can contribute to a serious outbreak. So then we set up in Conakry, and that's when I went. I went there at the end of March, and we were really trying to hope that we could just nip it in the bud. And we were working on it, and sure enough, we started seeing more and more patients, and we were sending out public service announcements to the world, to Conakry, about what this disease is, because they never knew about this, they never heard about this, and so they were naive to it. And we really tried quickly to educate them, but then it quickly just spiraled out of control.
So at this point, how many documented cases are there in Africa?
At this point, we're over 13,000.
This is Science for the People, and I'm talking to Tim Jagatic, who has worked in Ebola response for the last year in both Guinea and Sierra Leone with Doctors Without Borders. Okay, now you touched on treatment. So is there a pharmaceutical treatment for Ebola?
Well, there are some vaccines and treatments which are in the pipelines. They are working on them. Soon they will begin trials on the ground. So far, some phase 1 trials, which means trials on healthy people who are willingly, voluntarily trying them here in the West, have already begun. But fairly soon, within the next month or so, actual trials within the field are going to start. But up until that point, though, we still have to focus on, we have to understand two things. The first is that the supportive care that we are giving at this moment is bringing down mortality rates significantly. The second thing is we have to make sure that we don't abandon supportive care in favor of vaccines or treatments, because if they don't work, then we still need to have that plan B set up. We're still going forward with the vaccines and the treatments. We are part of the group, the consortium that is working on trying to figure out whether these are effective or not. But we also have to keep in mind that if they don't work, we still have to be able to provide proper supportive care.
Can you just define supportive care for folks?
Sure. So supportive care is essentially symptom relief. When we see patients who are vomiting, we give them medication that helps them stop vomiting. When we see them having profuse diarrhea, we try to give them fluids to replace everything that they're losing, as well as the electrolytes that they're losing. And before this outbreak, this was the outbreak where there was the first time there was a real clinical push to help patients rather than just try to stop the disease from spreading. For the longest time, this disease wasn't very well known, and practices beforehand were about containment. But over time, as there were about 20 outbreaks since 1976, little by little was learned with each outbreak. And finally, with this one, they decided we know enough about this disease, we understand the transmission, that it's time for us to really start pushing for clinical care. And when we saw this 90% mortality rate associated with the disease fall to 50% with very basic supportive care, we're talking just fluids and Tylenol and a little bit of food, then we really start to get extremely encouraged about what more can we do. And sure enough, when we start to get even a bit more aggressive with our therapy, we saw our mortality rates fall even further. So essentially what we were doing was we were realizing that this disease was fairly treatable. And the more we learn about it, the more we realize that there are certain weaknesses that this disease has and certain advantages that we can take advantage of. And that's why we were really starting to push for more help in this situation, because it wasn't as bad as it seemed. Like, we were able to demystify this. We were able to destigmatize this amongst ourselves. And we really started to push for more help because we saw, wait a second, if we have more help just on these lines, on the fact that we can get more people helping us on supportive measures and going out into the villages, treating and educating the people out there about how this disease is being transferred, then we can help stem the tide of the transmission of the disease. And unfortunately, for a long time, there was a fairly slow response.
Well, I'm wondering about the quarantine protocols, because that seems to have been an issue, that there were a lot of problems with keeping sick people quarantined. So what were the obstacles?
Well, it's In terms of quarantine, I think that was, first of all, quarantining, if we can go back to the concept of West Africa and this idea of trying to quarantine all of West Africa and let the disease fizzle out there and we won't have to worry about it over here, that was a very poorly planned idea based off of simple and erroneous logic. And the logic is if you stop them from coming, they won't come. But unfortunately, people don't realize that human emotion and human behavior goes beyond human logic. And people who want to get out will get out. They can find ways to get out. And if they do get out and they're under the feeling of being persecuted when they get out, they'll go underground and they'll hide. And if you have somebody hiding in your country with Ebola, not telling anybody about it, and they are getting other people potentially infected, that causes a lot more problems than if a person simply gets to your country, develops the symptoms, goes to the hospital, and gets treatment. Those are two completely different scenarios. One is extremely dangerous. The other one has almost zero risk. Now, the concept of quarantining individuals coming back from West Africa, that perpetuates the stigma of this disease. When you're telling somebody you cannot leave your home for 21 days because you run the risk of infecting other people, then the people don't fully understand what's going on. They assume that you're in a state of extreme susceptibility, that you are extremely contagious, and that if you leave the walls of your home, you will infect the entire neighborhood, which will then turn into the entire city and then the entire country. Meanwhile, that's not the case at all. The system that we had set up through MSF was evidence-based. We used an evidence-based method which consisted of self-monitoring. And that self-monitoring consisted of us taking our temperatures twice a day, or if we started feeling sick, we would then notify the proper health facilities. The health facilities which were already aware of us being in that community and would be ready for us in the event that we would have to come. In the meantime, while we are doing this self-monitoring, we would be resting because we just came back from an extremely difficult mission, and we would go about daily chores. We would be able to go to the grocery store. We would be able to go for walks in the park. We would be able to meet up with friends. But on a personal level, we also decided to make sure that we would not engage in physical contact with people. Not for them on a scientific level, but for them for a state of peace of mind. Right. Because it actually happened to me where a friend of mine wanted to give me a hug. I said, well, I'm still in this 21-day period, better not. And 2 days later, she got sick. And I can only imagine what would have happened if she had a hug from me and 2 days later got sick. She would have freaked out. Simply because she would have hugged the guy who was still under, quote-unquote, Ebola quarantine, which is not the case. I didn't have any symptoms. I could not transmit the disease, but that doesn't necessarily matter to somebody who just gets sick after having contact with the quote-unquote Ebola guy.
Emotion is definitely more powerful than fact in many situations.
Exactly. And we're seeing that, and we're respecting that. But at the same time, we're trying to educate. I mean, I'm not going to force contact among people to prove that I don't have Ebola. But I will sit there and discuss what this disease is. And I think that if we do that, then we can kind of get the same understanding of this disease on a general level that we have about HIV. Because today, in this day and age, we don't have that same fear associated with HIV that we did in the 1980s. And I think that we can get to that same level with Ebola.
Tim, thanks very much for being here.
Thank you very much for having me.
And we've linked to Dr. Tim Jagatic and Doctors Without Borders on our website at scienceforthepeople.ca. And we'll be back with more discussion about the Ebola outbreak with epidemiologist Tara Smith after these messages.
Science for the People is a weekly radio show exploring everyday life from a scientific perspective. To find out where Science for the People airs near you, or to listen to past episodes, check out our website at scienceforthepeople.ca. You'll also find links to connect with us on Facebook, Twitter, and Google+, or to subscribe to the podcast in iTunes. And now, back to the show.
Welcome back to Science for the People. I'm Desiree Schell. I'm here now with Dr. Tara Smith, an associate professor of epidemiology at Kent State, who studies zoonotic diseases and was the first to identify livestock-associated strains of methicillin-resistant Staphylococcus aureus, or MRSA, in the United States. Dr. Smith has published over 50 peer-reviewed papers and book chapters and has written books on Group A streptococcus, Group B streptococcus, and Ebola. She also writes about infectious diseases for Slate.com, Mic.com, and her own blog, Etiology. She's also a member of the advisory board of the Zombie Research Society. Welcome to the show, Tara.
Thank you for having me.
So we just spoke to Dr. Tim Jagatic about Ebola in Africa, and I'd like to talk to you about what's going on in North America. So how did it make the jump to this continent?
So a couple different ways. So medical workers have been brought back here who were already infected with Ebola that they acquired from working with patients in West Africa. And the one case that did end up dying and causing secondary transmission was Thomas Eric Duncan, who was also infected in West Africa and traveled to the United States during the incubation period, came down ill when he arrived back in Dallas and reported to a hospital there.
So what's the usual process with something like that, with outbreaks? How do we prepare for or maybe react to outbreaks that are currently only seen in another country?
Usually badly.
That's where I was going.
Oftentimes there's an adage in epidemiology and in medicine that when you hear hoofbeats, don't expect zebras. And so that just says that, when you see something that maybe seems weird or exotic, usually it's not going to be. Usually it's going to be something run-of-the-mill. In this case, we were at least had some advance warning that obviously we knew about the outbreak of Ebola that has been occurring for almost a year now, percolating in West Africa. And so we knew there was a chance that Ebola may be imported into the United States. In Texas, it looks like they just, they dropped the ball. They missed a lot of factors that could have perhaps identified Duncan's infection earlier and potentially, maybe treated it earlier and led to a better outcome. But just because we're so used to thinking that way, to thinking that it's going to be something that is usual, something that we see in the U.S. all the time. It's sort of a different mindset to actually treat what we consider an exotic disease here.
So now, how do healthcare professionals get the news that they might want to watch out for something? How is it disseminated, that information?
A lot of different ways. There's an email service called ProMed that sends out just email blasts several times a day discussing outbreaks that are going on around the world. In some cases, there will be CDC alerts. In some cases, it's just local news stories. So there's lots of different ways that this type of information can be disseminated.
Well, let's talk about the different quarantine rules. Are quarantines different in different countries, in different regions?
It totally depends on the disease, the area. So typically a quarantine is when you put somebody into isolation. It can be in their own home. It could be, in a hospital facility, in a prison. It just depends. But it's someone who has been exposed to a disease but is not yet themselves ill. So what you want to do is prevent them from spreading the disease before they know that they're sick. So that's what it's traditionally been used for, and quarantine does have the force of law. So you can have someone who is under quarantine, be legally bound there, have some kind of a law enforcement presence, or in some cases, depending on if they are in a hospital or a prison or something like that, be under guard while they're watching to see if they develop disease.
Now, I've heard a lot of reports about voluntary quarantines in the U.S. So in what cases would those be used?
Yeah, they've used some of that here in Ohio. So when we did have Amber Vincent, the nurse from Texas, who traveled to the Cleveland area while she was still in that incubation period and then returned to Texas and was diagnosed with Ebola. So they did have a number of people who were in close contact with her family members, just basically stay home, not go out in public, have meals delivered to them, not have contact with other people, and voluntarily basically isolate themselves in their homes during the incubation period. So, and that was kind of what the news producer was supposed to be doing in New Jersey as well, that she was supposed to be under voluntary isolation. So that didn't have the force of law because they had agreed to it and agreed to do this themselves. But it's a similar situation that basically they would just stay at their home and shouldn't be leaving and shouldn't be out in public.
But she did go out in public, and people freaked out.
Yes, yes. And, in that case, again, she was already well into the incubation period, not symptomatic at that point. But just because it was a breach of what she had said she would do, I think that's kind of understandable that people were upset because she had already agreed to it in principle.
So maybe just personally unethical, but not criminal and not exactly scientifically wrong.
Right, and that was in the case of the newspaper, the news producer or journalist. With Amber Vinson, I don't believe she had ever said that she was told to voluntarily completely isolate herself, and she did say that she had been cleared by her hospital to travel. So her case was a little bit different in that she hadn't agreed apparently to voluntarily isolate herself.
Well, is North America kind of maybe overcompensating a bit now? Because I've heard that people are being quarantined but showing absolutely no signs of Ebola, and maybe, it's not even proven that they came into contact with it.
Mm-hmm. Yeah, there are, I saw in the news there are apparently some people being monitored also in Illinois for exposures. Obviously, Casey Hickox, the nurse who came back, and was immediately quarantined in New Jersey after some of the new rules were put in place about quarantine of healthcare workers coming back from working with Ebola patients, got caught up in all of this mess. So I think it is, to my belief, an overreaction. The thing with quarantine is that it's most important when you have a disease that people can spread before they have symptoms. So something like measles, where people can go out several days before they show any signs of rash or fever and still be spreading the virus to others, and it spreads through the air, so it's very transmissible. With Ebola, as far as we've ever seen, you can't spread this before you are symptomatic. And not only, symptomatic in the early stages, but really, vomiting and having diarrhea and are really ill. So a quarantine for Ebola, even biologically, doesn't really make sense because you're not going to be out spreading it when you're asymptomatic before you know that you have the active infection.
So it's not just the U.S. that may be overcompensating, it's Canada. Canada recently started denying visas to people from Ebola-affected countries. What are your thoughts on that?
Yeah, I also disagree with that, because I think so do most global health agencies around the world, that this is really a counterproductive move that is not really going to help anyone and not really going to play a role in keeping the virus out of the country. As we've seen in the U.S., most of the importations have been from healthcare workers that already knew they were exposed or in some cases were sick. And I think the same thing would probably happen with Canada. We did have, of course, the one case of Mr. Duncan that a visa ban may have prevented. But I think if you're well prepared for this and looking out for that, then a visa ban is going to stop the needle in the haystack. But while you're doing that, you're allowing the outbreak to flare up in West Africa even worse than it already is, because you're really discouraging people from going over there to work and really cutting off those countries.
But is it effective at stopping the transmission of Ebola?
It can be effective potentially to quell the number of people who are bringing it into the country. Just because, again, you're banning travel from about 12 million people in those 3 affected countries. But again, it can come in other ways, in healthcare workers and things like that. So I don't think travel bans and visa bans and things like that are really the way to go for this. I don't think it's going to prevent enough cases to make it worthwhile.
And of course, there's always the chance that denying visas to people will just push international travel underground where it can't be monitored.
Right, absolutely.
This is Science for the People, and I'm talking to Dr. Tara Smith, an associate professor of epidemiology at Kent State, about Ebola. So what would have to happen for us to start seeing more cases here? How could it all go wrong is, I guess, what I'm asking.
I mean, as the outbreak increases in West Africa, then of course you will statistically increase the probability that someone coming from one of those countries will come in and be infected during the incubation period, not showing symptoms yet, and develop symptoms while they're in the United States. Also, obviously, as more healthcare workers do go over there, they may also become infected over there and bring it back here. But As I understand, training programs have been put in place even for healthcare workers that are coming from the United States. The CDC has programs to train them before they go overseas. So, I don't see it exploding here. We'll probably have, as long as the outbreak is going on in West Africa, a few cases may dribble in here and there. But I think as long as they're detected quickly and routed to the most appropriate hospitals, which many states are now, identifying, I don't think we'll see the problems that we saw with Mr. Duncan's cases, his case in Texas.
And I think people are probably a lot more aware that the symptoms that people could be showing when they come into the hospital could be Ebola.
Right. And, other hospitals around the country have seen the missteps that Texas Presbyterian made, and no one wants to be that next hospital that does that. So, I think that is something they're very cognizant of, and certainly they're at least working on procedures. Whether they have them in place by now or not is another issue, but certainly they are being investigated.
Well, the mathematical models of Ebola seem to be hopeful. There was an article on Nature News claiming that the models, however, overestimate Ebola cases. What do you know about that?
I haven't seen that one in particular. There've been a lot of modeling papers out, some of them conflicting, and it's so hard to tell because the outbreak is changing day by day. We've seen cases decreasing in some areas of Liberia, which has given some people hope. Others have been a little more pessimistic, suggesting that it's just because it's decreasing in some areas. It may be flaring up in others. So those models are just so variable to what changes in these places day by day, and it's just really hard to tell where all of this is gonna come out.
But I'm wondering if you aren't all being overly conservative, so we don't all panic.
And that's definitely a criticism that's been levied against scientists, and especially the CDC, for coming out with this kind of "don't panic, we can handle this" attitude. And then, with Mr. Duncan's case in Texas, of course, that led to 2 secondary cases in the nurses. So that's definitely a potential criticism. And I don't think anyone is really that optimistic right now, or that having as much of a don't worry attitude about the situation in West Africa, where it still is bad. There have now been over 13,000 cases and about 5,000 deaths. And even though, again, there may be some optimism for that waning in some areas, it still is far from over, the epidemic there. So, I think there is definite, some definite agreement that we can't make things too rosy, even for here in the United States. But I think we've seen with all the patients we've treated so far, I think we were up to 9 now. 1 has died, the other 8 have recovered. Dr. Spencer was just released from his hospital in New York City yesterday or today. And so I think we've shown that we're doing a pretty good job of handling it here in the United States. And I think any future cases, hopefully, will follow that model. Again, we can't ever be certain, but I think we're doing pretty decently so far.
If you don't mind, I'd like to talk about something you just mentioned, the fact that the CDC is sort of accused of maybe not releasing all the information they could, or just its basic focus is to make us not panic rather than provide us with information. And there are people who think that the CDC isn't objective. So, and I'm not talking about people who type in all caps on the internet either. This is the perspective of some rational people. So what do you say to them?
Yeah, it's difficult. I've worked with a lot of people that are, at the CDC or in other levels of public health that do similar things. And so, I know a lot of these people personally. I trust them. But a lot of people, of course, don't have that experience, or have the opposite experience, that they've, just don't feel like they have any trust in government or in public health. So it's tough to shake off. And then you get some of these rumors that spread on social media and on the radio and things like that confirm those fears for people. So I think those are hard to shake, and there's not really much that one can do in public health besides point out the successes that CDC and others working with Ebola in the United States have had, and point out the positive things that they've done and the things that they've said that have been confirmed as far as, Ebola transmission in the United States. We haven't seen it in the community. The only transmissions we've had have been in the hospital. So, what the CDC said from the start regarding the unlikelihood of a community outbreak of Ebola has come true so far. So I think you can really just kind of cement those types of things and, work to show what we've done right and where they've made successful predictions.
Well, speaking about rumors, there are some spectacular Ebola rumors. And just from a brief perusal of the internet, I'm just going to read these out. I found everything from allegedly documented cases of Ebola being transmitted by air, claims that the Ebola outbreak is a hoax, with the deaths in Liberia actually being formaldehyde poisoning. There was a video about the U.S. having engineered a crisis by planting Ebola in Africa. So have you seen all those types of things?
I haven't seen the formaldehyde one, but yeah, they all kind of had the same general structure, right? That, either some way that the U.S. government or in some cases private pharmaceutical companies or something are, lying to us, are deliberately, planting Ebola in somewhere, have deliberately sparked this epidemic in some way or another, whether it's through, poisoning or contaminated vaccines or illicit drug trials in West Africa, things like that. So there are a lot of rumors out there.
It should be noted that these same rumors or very similar rumors happen during every outbreak or
yes, yeah, absolutely. Again, there are a lot of parallels regarding the response of the public to this Ebola outbreak that have been seen with HIV/AIDS as well. There was just a recent paper published on that, either JAMA or the New England Journal. So, like HIV/AIDS, we've seen a lot of the almost exact same rumors as far as, Ebola coming from vaccines, just like it was suggested with HIV/AIDS, that it's a way to depopulate Africa, just as was suggested with HIV/AIDS. So you get a lot of this kind of recycling of the old stuff that didn't really work with HIV, but maybe now it's true for Ebola. And I think there's still a lot of, because it is a lot of Western charities and things like that are responding to this, as far as Doctors Without Borders and Partners in Health and CDC and others. There's still a lot of distrust, of course, of Western European people going into Africa and working to treat this. And there's just a many century legacy of colonialism and everything else there that works to allow these rumors to adhere, to take hold.
Right. But then should the medical community publicly respond to these kinds of rumors or not? There are two schools of thought on that. If it's mentioned, even to provide proof that whatever YouTube video is a hoax, studies seem to show that a kind of confirmation bias called the backfire effect might cause people to falsely remember the video as being true instead of something that was disproven. But on the other hand, if these things aren't mentioned by the media or the scientific community, it's absolutely used as fodder for the they don't want you to know folks.
Right.
So what are your thoughts on how to publicly deal with these kinds of rumors?
Yeah, so there's no good way to approach it. If you ignore them, they're not going to go away. They're just going to get perpetuated further. So I don't think it's appropriate in most cases, and there may be exceptions, but for the CDC or other types of organizations like that, the ones who are really leading the fight and who are most visible, for them to respond to that. I kind of see it as akin to, almost akin to creationism, that, for the biggest evolutionary biologists to go out and debate creationists who think that the world is 6,000 years old and, everything was created and there's a great flood 4,000 years ago. That gives them respectability, and that allows those rumors, I think, to keep going because the big wigs take notice of them. So I don't think it's something that CDC and others need to respond to. I think it is something, a place where journalists and where, scientists like me who don't have as big of a stake in all of this can take on some of those rumors and, maybe show how some of them are either recycled from previous outbreaks or why they may be patently untrue because, here is XYZ that shows that just could not happen. I've talked a lot about airborne Ebola on my blog and other places, and trying to explain how most of the studies done with that have been in laboratory settings where the virus was artificially aerosolized, and it's not something that we see in an outbreak setting. So I've tried to, me and many others have tried to explain some of the science of that for people who are actually looking for explanations. And of course, you're going to have people that no matter what, they're going to believe those type of rumors. But I think for a lot of people that are, just kind of taking in this information from anywhere and don't have any kind of really alignment either with, the science side or the rumor side, and are just trying to find things out. I think the information that journalists and scientists can provide to debunk some of those rumors is really important.
So what would you suggest for people who are concerned because they've heard one or another of these rumors that are going around?
There are a lot of great, kind of skeptic blogs, science blogs that have talked about these. They did get some coverage in, I think, the New York Times that at least mentioned some of them a little bit. So there's, Snopes actually has taken on a few of the Ebola rumors. Yeah. I think they had an article on one or two of those. Maybe it was the CDC, one of the early ones going around was that the CDC had this patent on Ebola a few years ago, and so they were, producing it en masse to release it during this outbreak. And the real story is that, they have a patent on this virus just so that other people can't patent it and then, refuse diagnostics or things like that to them. So some of that has been addressed on kind of regular type of debunking websites, and Snopes is usually a good place to at least start for some of those answers.
So I guess the big question at this point is just how worried about Ebola should we be at this point?
If you are in the U.S. or really anywhere in North America, probably not very. I wouldn't be surprised if we do see some more importations, especially if this lasts until next summer or beyond. So some more cases may pop up in the United States. We probably will see more people being monitored as they come and go from West Africa. But I don't see a big potential for any kind of community-associated Ebola outbreak. I think the people that do need to be concerned are healthcare workers that are on the front line, and that they do need to, to work with their hospitals to make sure that they get training and they know procedures that they can follow if there is a potential Ebola patient.
Now, did you just hear about the strike that's happening among the nurses who don't consider their hospitals to be adequately protecting them from Ebola?
I did, and that's one of those groups that, I think they're much more right to be concerned than, your average citizen who is probably not going to have any contact with any potential Ebola patient. So I do think they're healthcare workers, they deserve training, they deserve to know what to do. Of course, it's difficult because everything is constrained by funding. And, these types of issues regarding basic public health are often very underfunded until you get into a crisis situation like this, and then it takes a lot of time to get money allocated. So it's a difficult situation.
So what should I tell people who desperately don't want me to travel right
now? Travel anywhere? I'm still traveling. I was just on a plane last week, so I don't worry about it. Do your normal precautions. Wash your hands a lot. Try to avoid coughing on people and getting coughed on and things like that. But Ebola is not much of a concern for me. Be much more concerned about influenza and other kind of winter respiratory and vomiting infections.
Should we avoid traveling to specific places, though?
I didn't even think so for that. Certainly, if you're planning on traveling to one of the affected West African countries, I would think you would want to have a good reason for that right now, just because so many things are going on there, and you don't want to step in the middle of something that you don't know what you're what you're getting into. But I know even in other not even West African countries, but just African countries in general, they've been hit hard with tourism because people don't want to go there, even if it's Kenya, which is I don't know how many thousands of miles away from these affected countries. So any of those I would not, if I had an African safari planned right now and people were worried because of Ebola, I would still definitely be going on that. I wish I had one planned.
Is there anything else that you'd like to leave people with that you think people should know about Ebola or this specific outbreak but don't?
Just that there are a lot of great places to donate. A lot of people, I think, they hear this going on, maybe read some of the news stories and don't know what to do. Facebook just had kind of a drive for Ebola donations. Google, I think, is matching donations $2 for one. So there are a lot of great places to donate, great charities who are doing, work on the ground with this. So if you are stymied with what to do, move with your wallets, and it's the giving season. So check out some of those charities that do a lot of great stuff with Ebola and give that way.
Tara, thanks very much for being here.
Thank you very much.
And that was Dr. Tara Smith, Associate Professor of Epidemiology at Kent State. And we've linked to her and her work on our website at scienceforthepeople.ca.
You're listening to Science for the People, and don't go away. I'll be back after the break with immunologist Vincent Racaniello to find out where we are with developing Ebola treatments and vaccines.
Science for the People is a weekly radio show exploring everyday life from a scientific perspective. To find out where Science for the People airs near you, or to listen to past episodes, check out our website at scienceforthepeople.ca. You'll also find links to connect with us on Facebook, Twitter, and Google+, or to subscribe to the podcast in iTunes. And now, back to the show.
Welcome back to Science for the People. I'm Rochelle Saunders. With me is Dr. Vincent Racaniello, a professor of microbiology and immunology at the College of Physicians and Surgeons of Columbia University. He has done laboratory research on viruses since 1975, and over the years he has studied a variety of viruses, including poliovirus, echovirus, enterovirus 70, rhinovirus, and hepatitis C. In addition to his academic work, he blogs at Virology Blog and hosts 3 podcasts about virology and microbiology. This Week in Virology, This Week in Parasitism, and This Week in Microbiology. And he's been regularly discussing the Ebola outbreak on his blog since the outbreak began. Thanks very much for joining me today, Vincent.
You're welcome. My pleasure.
So right now, is there a pharmaceutical cure for Ebola?
There is no cure. There is no approved vaccine or antiviral that can be used, although a number of them are in development and some of them are being deployed on a small basis to infected patients.
So some of these experimental, I don't know if they're drugs or necessarily vaccines, I'm not sure what the right term is, but some of them are actually being used on current patients?
Right. So there are 2 categories. There are what we would call drugs or antivirals, and then there are vaccines. So a vaccine, of course, you give to someone ahead of time in anticipation of being infected. And we don't have any of those being used at the moment, although there are a couple that are being tested. And then the antivirals are compounds that can be given to people who are sick in an attempt to stop the infection. And there are a number of those that have been tested in the laboratory. You may be aware of one in particular called ZMapp, which is actually a kind of different antiviral. It is a mixture of antibodies. So antibodies are what we make when we're infected with pathogens, and we use them to fight off the pathogens. So this is an artificially assembled cocktail of antibodies, and it has been given to a few patients and is now going to go into further trials as well.
So how successful have some of these experimental antivirals been so far?
They have all been tested quite extensively in animal models. So for Ebola virus, we have a mouse model that can be infected with the virus, and we also have non-human primates, macaques, for example, that can be infected, and they show a disease that resembles the one in humans. Both the vaccines and some of these antivirals, including this ZMapp antibody cocktail. They've been tested in the non-human primate model, and they're quite good. They confer protection, and in the case of the antivirals, you can actually give the drug to the animal a few days after they're infected and still see protection. So for a number of them, I would say so far they look really good in the animal studies. But of course, the next step is to put them in people, and that's the hard part.
So where are we with trying these out on people?
So there are a number of vaccines that have come up to the point where they're ready to go into people, and that's being done or is about to be done. And there are at least 2 candidate vaccines, probably more, that are going to be tested in what we call a phase 1 clinical trial, and that's simply to know if they're safe in people. Just because they've been safe in animals and protective in animals doesn't mean that they're going to be safe in people. So we need to do a small phase 1 trial of maybe 20 or 30 people, inject them with the vaccine, and just make sure there are no serious side effects. And if that looks good, then you can proceed with additional testing. And the same goes for the antiviral compounds. There are a number of them that are actually ready to go into phase 1 trial. These are actually some compounds that have been tested in humans for other virus infections. So they've already gone to a pretty far point in the trialing, and now they can just be tested for their efficacy in Ebola. So it's very early in both cases for the drugs and the vaccines, but the good news is there are quite a few candidates, and within the next few months we should see which ones are safe.
So let's talk a little bit about timelines here. We're obviously still in a trial period with a lot of these vaccines, but there are a lot of people who could really benefit from using these vaccines if they prove to work. So what's the timeline for the experimental process and getting them through the trials to when we might actually be able to use this practically?
So the phase 1, the safety trials, these could be completed by the end of this year. Right? Those are not that's not a lot of work. The real issue is, what do you do next? Because we do have an ongoing epidemic, and you would like to save lives. In normal circumstances, if there weren't urgency, you would do a phase 2 clinical trial where you would give the vaccine or antiviral into many more people, and then you would try and see if it works to protect them from infection. Now, the problem with Ebola is that the outbreaks are pretty random. They occur here and there and without much warning. So it's hard to immunize a population and then say, is this protected against an infection by Ebola virus? The alternative is, what we can do is, in this current outbreak, we can go in and immunize a lot of people in the outbreak area and then see if that has an effect on incidence of disease. Now, that requires lots of doses, so the manufacturers have to make the vaccine. So realistically, we're talking about at least 6 months, and I think WHO has said they would have 1.5 million doses of at least one of these vaccines by the end of 2015. So it's not imminent, but it's better than 10 years off.
From outbreak to the delivery of vaccines to people on the ground, how long are we actually talking about here?
To getting vaccine to people who need it, at least next summer, most likely, and more realistically, in substantial numbers by the end of next year. So it's possible that in the spring there might be thousands of doses available, mainly for healthcare workers to make sure that they don't get infected and spread the disease. But distributing it in the population is going to take longer, because we really need to do some efficacy trials. It's fine to say that this vaccine or antiviral is safe in people, but you really need to know if it works before you give it to tens of thousands or millions of people. And that's just going to take some time, which is why I'm saying middle of next year or end of next year.
I want to talk a little bit about the pharmaceutical company angle here, because there's been a lot of public discussion about that. The widespread perception at a certain point during this outbreak was that if a pharmaceutical company couldn't make money off an Ebola vaccine, they wouldn't make one. Poor countries didn't get the drugs. So pharmaceutical companies would wait until there was a chance of making a profit, and therefore wait to release vaccines until Ebola hit North America, where people are willing and able to pay for them. Is that perception at all accurate?
I don't think it's fair to blame the companies in that way. I think that companies are in business to make products, and they have to pay for them. A drug or a vaccine can cost $1 to $2 billion to bring to market. It's very expensive, so they have to be able to recover their costs. Otherwise, they're not viable as a business. They'll go out of business. And for Ebola, the market was and still is relatively small for this vaccine. When you consider the other vaccines that we use, polio, measles, influenza, for example, millions and millions and millions of doses are used every year. And in this case, we may make a few million doses, but it's not really enough to sustain a product. What you need here is collaboration between governments and pharmaceutical companies. And that has happened in the past, and that's what you need when you have a virus that is dangerous but doesn't seem to infect a lot of people, but you should still be ready. So the companies, in fact, some of these vaccines that are going forward are collaborations between the NIH in the U.S., also some Canadian agencies and companies as well. And now the next step is being bolstered by governments who are putting money into it. So this is actually a nice lesson to learn that there are going to be lots of diseases for which you're not going to sell millions and millions of doses. So the governments have to step in, have some foresight, and say, we need to have a stockpile of this vaccine. We're going to collaborate with companies and make it financially realistic for them to do that. So while it's certainly true that companies need to make money, otherwise they won't exist. In cases like this vaccine, governments really have to come to the rescue.
So just for a little bit of general information, how much does a vaccine cost to research and develop?
So from day one, when you first have an idea that you want to make a vaccine, through all the laboratory studies, the studies in animals, and then the clinical trials, probably $2 billion, and that increases every year as everything gets more expensive. The clinical trials in particular, where you have to enroll patients, this has to be done through hospitals, and you employ physicians and nurses and healthcare workers, and you have to collect data, you have to manufacture the vaccine, so it's quite expensive. And so companies can't afford to spend $2 billion over, say, 10 years and then not make any money. They'll go out of business. But let's just consider the following. The U.S., Obama has asked for, I think, $7 or $8 billion in emergency appropriation to help with the effort in Africa. If that had been spent in the previous 10 years, we could have 4 or 5 vaccines and antivirals ready to go today. So that's why I'm saying I hope that we learn something from this outbreak, that we really have to look forward and try and predict what's going to happen and be ready.
I've heard that there's a program in the U.S. where pharmaceutical companies can essentially get, I don't know what the right term is, but I'm thinking kind of bonus points or like a bonus voucher they can use if they do some research for rare diseases that then they can use to help fast track some of their other drugs through approval. Is that something that might apply for something like this Ebola vaccine?
I'm not aware of that, but I do think that the companies have to work with the government and say, look, we have the technology to make this vaccine or make this antiviral. We need your help. And it's really up to the governments. And to this point, the U.S. at least has not thought it worthwhile to invest in these vaccines. Now, they have paid in part for their development, and that's because I think they were going to be used for people researching the virus in case they got sick or to protect them, and healthcare workers. So there hasn't been a big effort. And I think deals like what you're talking about are a good idea. You have to provide some incentive so that the companies will do this. But again, on the other hand, the governments need to be more clairvoyant. They have to commit the money. And up front, $2 billion is better than $8 billion, right?
Do you think the public reaction to the idea of Ebola hitting North America will help that effort to try and get some of these rare diseases better funded by some of our governments, those ones that aren't necessarily profitable for pharmaceutical companies to make?
I do hope so. Unfortunately, everyone has a very short memory, so as soon as this outbreak is over, I'm afraid we go back to business as usual, and it's going to be up to scientists and legislators to keep pushing this. I do hope that we can look at a couple of other viruses and say, look, these are dangerous viruses. They're not spreading very much at the moment, but there is a potential. Let's invest $1 billion or $2 and save $6 billion down the road. So I have hopes. And, on my part, if I had any power at all, I would certainly push it forward. But it really depends on a lot of people, and it's not in any one person's control.
Vincent, thank you so much for being with us today and helping us understand a little bit more about the Ebola vaccines and what the obstacles are.
My pleasure. I love viruses.
If you want to learn more about Vincent Racaniello and his work, you can find him at virology.ws, and we'll have that link and many, many more available for you on the show notes for this episode at our website, scienceforthepeople.ca. You can also find us on Twitter, on Facebook, and on Google+, where you can keep up with the latest from the Science for the People team. Do also check us out on iTunes, where you can listen to our past episodes, subscribe to the show, and leave a review. Thanks for listening, and we'll see you next time on Science for the People.
Science for the People is recorded in Edmonton, Alberta. The show is produced by Rochelle Saunders. Ryan Bromsgrove is our promotions manager. Our social media manager is Chelsea Butler. K.O. Myers updates our website. Helen Quivalon is our publishing liaison. Ed Haynes is our guest coordinator. We get research help from Josh Witten. The show is edited by K.O. Myers and Ryan Bromsgrove. Our theme song was written and recorded by Fractal Pattern, and its title is Binary Consequence. The show is hosted by Rochelle Saunders, Marie Claire Shanahan, and me, Desiree Schell.